Test 1 2 1 2. Test 1 2. Testing 1 2. Test 1 2.
All right, I'm going to let you get yourselves settled, and then I'm going to get started so we can make sure that we have time for questions at the end. Not this one.
Have you got the green light on?
Yep. Can you hear me now? Can't hear me? Ah! Now you can hear me. All right. I am so mic'd up here. All right. So today what we're going to be talking about is fall prevention, and a lot of this is focused on outpatient fall prevention. But I will sort of point out to you as we go along where there's significant overlap, and there are some new developments that I want to make sure that you're aware of that the U.S. Preventive Task Force came out with literally within the last month. So just to let you know, I do have grant funding from the VA, and I will be getting an honorarium for this, and I'm not talking about anything off-label in terms of investigational use of anything. So I'd like to start by defining a fall, and that might seem really simple to you, but there's a method to my madness, so go with me. So there was actually an international work group that started and tried to define falls, and the way that they defined falls was that it was an event that resulted in somebody coming to rest inadvertently on the ground or a lower level, and it couldn't be a consequences of the things that you see listed there. So if someone hits you and you fall down, that doesn't really count as a fall. If you lose consciousness, so a syncopal episode is not considered a fall according to this definition. If you have a seizure, it doesn't count. So this was really the first attempt at trying to define what a fall actually is. A Cochrane review looked at research definitions, and this actually is translated into what we define in the medical system as a fall, is unintentionally coming to rest on the ground, the floor, or another lower level. And it doesn't count when people end up leaning up against a wall or catching themselves in that manner. The reason this is important is that if I were to stand up, lose my balance, and fall back down into the chair, by this definition, that's a fall. But I guarantee you that nobody's going to actually write that down as a fall. So that's never going to get captured. It really is when people land on the ground that we as medical providers start really paying attention. So there was actually a qualitative study of almost 500 older adults. And what they did was ask these people, how would you describe or define a fall? And most commonly, what these older adults talked about was slipping, tripping over my own 2 feet kinds of things. They also talked about loss of balance, injury, and obstacles. So the dog was in the way, I slipped, tripped, fell over the dog, kinds of things. And the important point of that study was that older adults typically associated falls with whatever happened before and the consequences, and particularly when we're talking about injury. So if they fell and ended up breaking a hip, then they absolutely define it as a fall. But if they slipped on something or tripped over the dog and didn't injure themselves, they may actually not define that as a fall. Well, that's important when they're in our exam rooms and we're asking, so have you had any falls in the last year? We might not be getting the information that we're really looking for. So how big a problem is this? Well, it's actually a global problem, so it's good to know that it doesn't really matter where you live. If you like fall prevention and are interested in this topic, you can live pretty much anywhere and have work. So what this shows you is the mortality rate related to falls. And you can see that the green is the lowest. So Africa and India have some of the lowest rates, and red are the highest rates of mortality per 100,000. So Europe has quite a high number of fall-related mortality. So just in case you haven't noticed, we're all aging. And in terms of, again, having job security as a geriatrician, I am so golden, it's not even funny. Because you can see that the baby boomers started turning 65 in 2011. And the statistic that we talk about is that every day for the next about 18 years, 10,000 older adults are going to turn 65. 10,000 a day. And the reason that that's important is that as a geriatrician, I'm not the only one taking care of these folks, right? All of you are taking care of these folks. And so this is one of those things that becomes imperative for all of us to be aware of, because we're all going to have to deal with it either clinically or within our own families. As our parents age or we age, our spouse ages, that these are the kinds of things that are going to be very important for all of us. So what are the statistics? 1/3 of community dwelling older adults who are over the age of 65 are going to fall each year. So 1 out of 3. And less than half of them are actually going to tell us as their healthcare providers about that fall. In about half the cases of those who fall, it's recurrent. So those are people that we really want to be paying more attention to because they're clearly having trouble. The other thing to know is that rates do increase as we age, but the other time that rates increase is during the month after hospital discharge. So there was a really nice paper that was published, and it's been a while, that demonstrated that over the course, really in the first 2 weeks after hospital discharge, that the fall rate popped up and then it settled back down. And any guesses as to why falls increase right after discharge? And pharmacy comes through, it's medication. So definitely one of the reasons. So could be new medications, it could be deconditioning from the hospital stay, it could be just illness severity, and we're discharging people a lot sooner, and so they haven't fully recovered. So there's a lot of reasons for that statistic. The other thing to know is that in the next 17 seconds, an older adult is going to be treated in a hospital emergency department for fall-related injuries. So it's not just that people have a high number of them are falling, but they actually are injuring themselves. And in the community, somewhere between 10 and 15% of falls result in some sort of injury. When you get into the hospital setting, that number actually goes up. So patients who fall in the hospital, the proportion of them who are more likely to have an injury that requires medical attention actually goes up to about 25%. And in the nursing home, it's actually a lot closer to 40 to 50% of them. And again, it has to do with frailty and the fact that those populations are kind of selective. It is the #1 reason for injury-related visits to the emergency department. And in 2015, it was estimated that there were 33,000 deaths that were associated with falls. And I'm going to share a little bit more about how that happens. You can see here, these are national statistics, and it shows that the #1 cause of non-fatal injuries treated in hospital emergency departments in the 65-year and older group is unintentional fall. But you can appreciate that all the way across the top there, unintentional falls are actually a big deal across the age continuum. So this isn't just an older adult thing. It really impacts from children all the way to older age. And the only place where you see something else coming in as number one is unintentional struck by or against in the 15 to 24-year-olds. And you can guess what that is all about. So what are the injuries that we worry about? And we'll get to hip fracture a little later. That's the one most of us think of first. But let me tell you a little bit about spinal cord injury. So what we are seeing with spinal cord injury is that the average age at injury has gradually increased. So it used to be that folks were in their 20s when they sustained this kind of injury. That has escalated to the average age now being 42. So you can tell that there's clearly people on the older age group to balance out those on the young. And the other thing that's happened is that there's been a real shift in the causes of spinal cord injury. So you can see in this chart that the blue, the biggest portion there, is vehicular, so motor vehicle crashes. But number 2 is falls. Number 3 is violence, sports, and then med-surg and other are the other categories. So number 2 is actually falls in terms of spinal cord injuries. And you can see in terms of, this shows you 2007, 8, and 9 in terms of the years. And the incidence is really much higher than we had appreciated. You can see on that far right bar graph the cumulative incidence of older adults who have sustained traumatic spinal cord injuries. And unfortunately, if an older adult does sustain a spinal cord injury, they are much more likely to have adverse outcomes. So not surprisingly, they are more likely to die in the emergency department. They're more likely to die during the hospital stay, and they're more likely to be discharged to chronic care, such as a nursing home, because there's not somebody who can care for them appropriately within their home. The other thing that can happen related to falling are traumatic brain injuries. And working in the VA, that's, again, not the first thing that I think about. It's much more likely to be, I think of blast trauma and the like. But yet in the Falls Clinic, we absolutely see people who have gone down and literally knocked themselves out due to this fall. And it actually, falls are the leading cause of traumatic brain injury. They account for about 40%. And in the older adult population, they're a little over 80% of the reason for the traumatic brain injury. Unfortunately, TBI-related hospitalizations are highest among our oldest old. So those who are 75 years of age and older are more likely to be hospitalized and more likely to die due to their traumatic brain injury. And in every age group, the traumatic brain injury rate is higher for men than for women, and I won't make any comment about that. So here are the leading cause of TBI, and you can see that 40% are falls, 19% are unknown. I'm not sure exactly what would fit into that category, but then getting struck, motor vehicle accidents, and assault are all in the mix. And then there's hip fracture. And anybody who is taking care of older adults has seen somebody who has had a fall that resulted in a hip fracture. And they can be quite devastating. The 2010 stats demonstrated that there were about 258,000 hospital admissions among older adults That's projected to get to 289,000, which is a 12% increase, all related to hip fracture. And most of the hip fractures occur when people fall onto their side. Basically, they just fall over. There's always the controversy, and I remember it in medical school asking, you know, was this pathologic, that the fracture happened and then they fell down, or do they fall down and break their hip once they land? There is no way that we're ever going to be absolutely sure of that, but for the most part, it does seem that the trauma is what causes the hip fracture, not a pathologic hip fracture. Women sustain 3/4 of all hip fractures, but that means men still get 1/4 of them. And again, our oldest old are the most likely to sustain hip fractures. And so this is a population of people who are frailer and have more difficulty getting around to start with, and then we add in a hip fracture, and you'll see what the adverse consequences of that are. One of them is that 1 of 3 who were able to live independently before that hip fracture end up remaining in a nursing home at least a year after that injury. So it results in a significant decrease in their ability to care for themselves, and so therefore they end up in the nursing home. If you think about it from a public health perspective, that means that really it's going to be Medicaid is going to be paying a significant portion of that individual's care needs, and so that means you and I are footing that bill for the nursing home stay. The other thing is that mortality is quite high in this population of people. On average, 1 out of 5 will actually die over the course of the next year. So it really is a marker of badness when someone breaks their hip. And here just is a graph just to show you women are on the left, men are on the right, and you can see the vertebral fractures that are radiologic, so they are not always symptomatic, are the green. The hip fracture is in the blue, and the wrist fractures are in the pink. And you can see that as people age, those numbers escalate, and even in men, you can see a big increase in hip fractures, particularly once they get to the 85 years of age. And I highlighted a little bit the mortality, that 1 in 5 actually die due to falls. This is just to show you injury deaths and unintentional falls. There were about 28,000 in 2015 that were related to unintentional falls. So again, morbidity and mortality are related to falling. And this is just to show you men are on the top, women are on the dotted line in terms of deaths per 1,000. So you can see over time the death rates from unintentional falls actually have gone up within the population. And this just shows you deaths by falls in people who were over the age of 65. And down there at the very bottom is Alabama. And I was delighted to see, and this is brand new data that just came out in early May, they were looking at the difference in fall mortality from 2007 to 2016. So for once, Alabama was not number 1. Yay! Exactly, like that's so exciting. So the important thing was that they really didn't see a significant change, whereas you can see up at the top places like Wisconsin and Minnesota and Colorado, some of those had really big changes from 2007 to 2016. So the other reason that we really want to pay attention to falls and fall prevention is what it's costing. And I've already mentioned the morbidity and mortality. From a patient perspective, those are really important costs. But the other thing is that medically, there are lots of medical costs that are attributed both to fatal and non-fatal falls. And right now, they are estimated to be as high as $50 billion. It is a huge chunk of the Medicare budget that pays for all of the different pieces that go into caring for somebody who is having falls. So in terms of the breakdown, you can see that the majority of cost comes from the inpatient hospitalization. So the surgery to repair the hip, the monitoring and CT and MRI that go along with head trauma, spinal cords. You can imagine the kind of cost that goes into caring for persons after that happens. But then there are also outpatient visits, emergency room visits. All of those lend themselves to increasing the medical cost. And fall-related injuries has been identified as one of the 20 most expensive medical conditions. So you can see direct medical costs for fatal injuries and non-fatal injuries, and the fact that the cost is escalating. So you can see in 2012, fatal injuries cost us somewhere around $616 million. By 2015, that had gone up to $637 million. And the average cost of for fall injury is about $30,000 per hospitalization. And unfortunately, the cost increases with age, and the costs were higher among women than they were among men. But again, there may be some issue with who is actually experiencing these kinds of injuries. The other thing that this doesn't account for is all of the other things that go into someone sustaining an injury. So they're now disabled, and that's evident by the fact that they may end up in the nursing home post their fall. They have dependence on others. There may be lost time from work and other household duties of whomever is their caregiver. So we know that somewhere between 80 and 85% of older adults have a female caregiver, whether that's the wife or the daughter. If it's the daughter, then she may not be able to work because she's caring for an aging parent. And then there's the cost of a reduced quality of life, and how do you measure what they are unable to do now that would have made their quality of life better. So if we were to look at risk factors, community risk factors are the area where we have spent the most energy from a research perspective. And we know that as the number of risk factors increase, so does your risk for falls. So this is my favorite slide, and I actually use this in my fall prevention clinic because it justifies why we do what we do. So you can see on the bottom the number of risk factors that someone might have, and I'll talk to you more in a minute about what those might be. And then on the side is the percent. So if you had no risk factors at all, you still have about an 8 in 100 chance that you're going to fall in the next year. So those are the accidental, wasn't paying attention to the sidewalk, or the dog ran between your legs and you ended up falling. But when you get to 4 or more risk factors for falling, now you have about a 78 in 100 chance that you're going to fall within the next year. So when we think about risk factors, what we really want to think about is decreasing the number of risk factors that somebody might have. Because you can see, if you go from 4 to 3 or 3 to 2, you actually are lowering the risk. You're never going to get the risk to 0. The research shows that. Life shows that. So 0 is probably not a reasonable option. no matter what CMS says. But you can see that we could potentially decrease somebody's risk. And these are the most common risk factors for falling. And number one on the list is muscle weakness. So if you have muscle weakness, you're 4 times more likely to fall than if you're strong. If you've already had a fall, you're more likely to fall again. Cognitive impairment is another one that we see quite a bit. If you don't have good safety awareness, you're going to be more likely to fall. And for my pharmacists, here are the medications. So there are a bunch of different medications that are associated with falling. Most of them are psychoactive kinds of medications. And one of the things that we do in geriatrics is really think about the balance between why you need the medication and any adverse side effects that you might have from it. So for example, if you are depressed and need an antidepressant, we acknowledge that antidepressants have the possibility of increasing your risk of falling, but so does depression. And in terms of quality of life, we do the balance and we go with the antidepressant. But I do want to point out, for example, benzodiazepines. Many of us are really trying to limit their use. That's hard when somebody comes in and they've been on Valium for 30 years. But this is a medication that we can wean people from. We just need to do it super, super slow, and we need to make sure that the patient is on board as we move to discontinue this medication. So what about where people fall? So here's a global report of the Epidemiology of Falls, and you can see that actually over half the falls happen outside the home. But a quarter of them happened on level surfaces. So this is the I tripped over my own 2 feet kind of thing. Shower and bath, I think we're all aware that that's a potentially dangerous place. On the stairs is the other one that is of considerable concern. And the other is 3% were falling off a chair or a ladder. Now I'm going to presume that it was climbing on the chair to change the light bulb or whatever, not that they just fell out of the chair. So what about strategies? So what do I do about this? I've got somebody in clinic. What are the kinds of things that I can recommend to reduce this person's falls? So there have been a little more than a couple, single intervention strategies that have been shown to be successful, and this is all evidence-based, research-focused kinds of interventions. One is the community-based balance and strengthening. So that first could be Tai Chi. And actually Steve Wolf, who is an investigator at Emory, was the first to demonstrate that Tai Chi could reduce someone's risk of falling by, in his study, 49%. I think the exciting thing about his study was not only that they were able to show that people decrease their risk, but potentially more exciting was the fact that the older adults who were in the class actually kept coming to class even after the study was done, which is really remarkable, because I don't know about you, but I hate to exercise. So the fact that these people volunteered to go continue to do Tai Chi, I think says a lot about the exercise. There have also been physical therapy interventions where it was a professionally supervised gait and balance training kind of program. They also were able to show a reduction in risk. Gradual discontinuation of psychotropic medications has also been shown to work. And then lastly, only after hospital discharge, but having an occupational therapist go to the home and evaluate for home hazards was able to reduce the risk by about 19%. So these are just single interventions. They weren't done together. They just went in and did one thing, and this is what they did. And you can see that the risk reduction ranged anywhere from 14 to 49%. The other thing that has been done and has been demonstrated to really have an impact is a multifactorial risk assessment with targeted intervention. And the key here is that you actually assess for all those different risk factors, and then you create a menu for the patient that addresses each of their risk factors. And the successful components are listed there for you in terms of what has been tried. And again, 25 to 39% risk reduction, which is not bad, but it's not zero. It's not that nobody is falling anymore. And according to the American Geriatric Society, these are the level of evidence. Now, this was published in 2011, and you can see that there are a couple of things that have grade A level evidence. So it's the multifactorial piece, it's the home environment, and it's exercise are the ones that got A's. The psychoactive medication withdrawal or minimization got a B, and then you can see that things like other medicines, postural hypotension, and thinking about footwear as well as foot problems got a level C evidence. One of my favorite studies, just thinking about cataract surgery, which gets a B, is there was a study done in Great Britain, and it could not have been done here, where what they did was they got a group of women who needed cataract surgery, and they randomly assigned them to either get immediate cataract surgery or to wait a year to get their cataract surgery. Now, if we told someone they could not have their cataracts done, they'd go down the street and they'd have it done by somebody else. So it could not be done here. But in Great Britain, they have a little more control over their healthcare system, and so these people had to wait. And what they did was monitored falls over the course of that year. And they were able to show a 39% decrease in falls in the group that had immediate cataract surgery compared to the group that had to wait. Now, when they went back in and did the second eye, it didn't make any difference. So the key point being that vision is really critical to fall prevention, and so it's one of those things that we need to be thinking about, is making sure that patients have optimal eyeglass wear, that if they need cataracts, that they get cataracts, etc. Because from a fall prevention perspective, it actually does matter. Now, this is where there's a little controversy that's bubbled up. So let me share with you what the American Geriatric Society said and then the newest information. So vitamin D supplementation has become really hot. Lots of us are checking and finding that our patients actually are vitamin D deficient, which is mind-boggling in Alabama where the sun shines a lot. But it makes sense because as we age, our skin changes, and oftentimes we're not able to make the change from sunshine into vitamin D. So initially, they were saying that if you have someone who had proven vitamin D deficiency, that you should be supplementing them with 800 international units or more, and that would actually help in fall prevention. Now, the reason for that is that we know vitamin D is actually a building block not only for bone, but for muscle. So there are receptors for both of those. And so that was sort of the thought, is that this is what we should be doing. And then their B level of evidence was that if you've got somebody who you think might be deficient or they're at increased risk of falls, just in general, that it's okay to go ahead and supplement that group of people as well. Basically, you're not going to do any harm as long as you're keeping the vitamin D level low enough. So their thought was that that was reasonable. Well, the U.S. Preventive Task Force folks came out with their recommendations in 2018, and I haven't seen any back and forth yet, but I'm anticipating that it's going to come. Because what they talked about was, in terms of falls, that they recommend the exercise intervention, that got a grade B, that they would recommend selectively offering multifactorial interventions to prevent falls. That only got a grade C, and they don't recommend vitamin D supplementation as a fall prevention strategy. So that's clearly different than what the American Geriatric Society put out 7 years ago. So in terms of their suggestion, they found insufficient evidence for vitamin D or calcium supplementation to prevent fractures in men, premenopausal women, and postmenopausal women at doses greater than 400 IU of vitamin D and greater than 1,000 milligrams of calcium. How do people feel about that? Yeah, cogitate on it, and we'll talk about it at the end. So, so that's a big difference in what we have talked about before. But if you're someone who has paid attention to the U.S. Preventive Task Force folks, they frequently come out with things that are a little bit different than the societies. So thinking about, screening for prostate cancer, they very much are at a population health perspective. And so obviously we need to think about what works for our patients, but it is a difference. So what about hip protectors? So there have been a number of studies looking at hip protectors, and there is pooled data from 14 nursing home trials. It's over 11,000 older adults, and they were able to show a small reduction in hip fracture incidence, but man, they are banging right up against that significance. As you can see, their confidence interval hits 1. The key was that 11 fewer people per 1,000 would have a hip fracture if they had hip protectors. In the community, the evidence isn't there. So there have been 5 trials at this point, just over 5,500 community dwelling participants. They've not been able to show any reduction in hip fracture incidence. And the major problem is adherence. So in case you've never seen a hip protector, these are what hip protectors look like. To me, it looks like a football pad, right? So they've got these big fat, either cushioned things that slide into pockets, or it's actually plastic that slides in. So as a female, I do not want any more out here than God already gave me. So, and that's what most women actually say. And so there's been a real issue with compliance. And as I tell my patients in Falls Clinic, they don't work if you fold them up and put them in the drawer. You kind of have to wear them in order for them to work. So I think until they become more attractive or they come up with different technology, it's going to be a problem to get people to wear them. In the nursing home, someone else is putting them on you, and so you have less say, and it may be that that's actually why they've been effective. So what about getting fall prevention evidence out into the world? So I wanted to share with you a study that was done in Connecticut, and what they were doing was comparing the rate of falls with need for medical attention in 2 different areas of Connecticut. And the goal was to disseminate fall prevention, because we know what to do, we just can't seem to get it out there into the community. So this was called the Connecticut Collaborative for Fall Prevention. And what you'll see is the green, which is kind of in the center around Hartford, was the intervention region, and there were 7 hospitals in that area. And then the blue is the control or usual care group. And investigators from Yale are the ones who actually did this study. And I can tell you that Yale was mad that they ended up in the usual care group, but funding actually came from a family who lived up in the Hartford area, and so that's why it got the intervention. So what they did was use practice change interventions. So again, one of the challenges is how do we get the word out? So they did everything. There was media attention. There were buses that had billboards across them about fall prevention. There were seminars. There was a website that people could go to get information. And then they actually got champions within the community. So they would talk with the discharge planners. They would talk with the physical therapists, with the OTs, with the physicians, anybody that they could talk to get them on board about fall prevention and the different tools that were available. So before the interventions, the rate of serious fall-related injuries were pretty equal between the usual care and the intervention region, as you can see. And then during the evaluation period, the adjusted rates were a little different. So 28.6 in the intervention compared to 31.4 in usual care. And the adjusted rate ratio was 0.91. And you're thinking, well, that's not very impressive. What the heck? I'll show you why it's important in a minute. They also looked at the fall-related use of medical services. So how often did people show up in the ER, in the hospital, et cetera? And it went up in usual care from 68 to 83 per 1,000 person years, and it went up from 70.7 to 74.2 in the intervention region. Now, I can tell you that there was an intermediate look during this study, and I was actually at Yale at the time, and this created some consternation because we were like, uh-oh, it would be really bad if we do all this fall prevention stuff and we actually make things worse, right? Luckily, that's not the way it turned out. So the adjusted rate ratio ended up being 0.89. So what does that mean in English, not statistics? It means that the adjusted rate of a serious fall-related injury was 9% lower in the intervention compared with usual care, and the adjusted rate of fall-related use of medical services was 11% lower in intervention compared to usual care. The other important thing is that these differences stayed even after the intervention and evaluation periods were done. So they kept keeping track, and this stuck. So what does this mean? Well, it means a potential savings of over $21 million in healthcare costs based on an average acute care cost of $12,000 per event. Well, I just told you that now costs are about $30,000 per event. So this really resulted in an impressive decrease in cost. So thinking about how we can disseminate is going to be really important. The CDC took this and ran with it, and there are a number of initiatives that I want to show you that are out there and are things that you can tap into and get pamphlets about. So one is a CDC initiative focused on traumatic brain injury and recognition of same in older adults who are 75 and older. And there's actually a whole website that people can go to. There's also a compendium that has been created that is really for public health practitioners and anybody else who wants to create programs that gives detailed information about how to utilize effective interventions. This particular compendium helps you define what elements need to be part of your program. It provides guidelines, program planning, development, so really kind of anything that you would need to create a fall prevention program. There's also something called STEADY. And this is an initiative, again, sponsored by the CDC. They have all sorts of pamphlets on the internet that people can access that range from what are the things you ought to think about looking in your home to what patients can do to reduce their falls. So again, lots of information out there that we just need to make sure that our patients get a hold of. And there's a whole STEADY toolkit that you could use in your own practice that would help in terms of disseminating that information. So in summary, falls among older adults are quite common. They're clearly a public health problem. The risk factors, we know what they are, and we know what interventions are going to work. So our major challenge, and I'm disseminating this challenge to you, is actually implementation and dissemination of these methods out into the world. And with that, I will stop and take questions. Thank you. You can clap, it's okay. Yes, sir.
Last I understood, having a natural fat pad on the lateral part of the hips does not help. Is that correct?
That's unfortunately, that does seem to be the case, that it does not disseminate or dissipate the force enough, and it doesn't help. The one good benefit, which I tell myself on a regular basis, is that having extra weight does strengthen bones over time. So there's the plus, is that if you're carrying around a little extra weight, then you've got more weight bearing. So, but good point. Thank you. Other questions? You gonna let me off that easy?